We are live.
Good afternoon, everyone. Welcome to this live webinar session being jointly organized by the Apollo Proton Cancer Center and the Times of India. Women's health play an important role in the overall well-being of a family. Any adverse impact on their health can affect the family dynamics, the finances, the mental health of its members. So it's therefore essential to create an awareness on some of the important health problems that could affect women, cancer being one of them. Breast cancer and cervical cancer are some of the commonest forms of cancer prevalent among women. We will be talking about identifying early signs, treatment procedures, and prevention mechanisms, and much more during the course of this webinar on cancer in women. We're joined today by Dr. Bhawna Sirohi. She's a lead medical oncologist at Apollo Proton Cancer Center. She's an experienced medical oncologist who has been in the field for over 25 years. She's an international senior consultant who specializes in the treatment of breast and gastrointestinal cancer. She also comes with rich experience of having worked in leading oncology centers around the world. We are also being joined by Dr. Kumar Gubala. He's a senior consultant surgical oncology at Apollo Proton Cancer Center. Dr. Gubala has been trained in some of the most renowned medical institutions in the world in the field of gynecological oncology. He's adept at open, laparoscopic, and robotic gynecological oncological procedures and has performed many complex surgeries during his medical career. Thank you so much for joining us, Dr. Bhawna and Dr. Gubala.
Thank you.
Yes. So, Dr. Bhawna, let me start with you first. You specialize in the treatment of breast cancer, one of the most common forms of cancer among women. Could you tell us from your experience on an average, how many cancer patients, breast cancer patients, do you see in a month? And is there enough awareness about this?
Good afternoon, everyone. Thank you, Pratibha. Yes, breast cancer is one of the core areas that I specialize in, and about half my patients would be of breast cancer and half with GI cancer. In urban India, the 1 in 25 women will develop breast cancer compared to rural India, where it is about 1 in 60 women will develop breast cancer. And I think Dr. Kumar will address that in rural India, cervical cancer is more common. And I think that is what we are seeing in the cities is I'm seeing more and more younger women with breast cancer. I think there is a change, there has been a transition in social and cultural factors where we are doing more office work, there are late marriages, there is a rush to come back to work after having had a child. So the period that women are breastfeeding is less. So all of these factors, the lifestyle related factors, which are responsible for more patients with breast cancer. Also, there is what we call screening. There is no coordinated screening program by the government of India. They have started a program where women from 30 years onwards have a clinical breast exam once a year, but no mammography screening program. So, but in private centers in corporate India, screening is done in urban India. So that also helps us in diagnosing more cancers. And at Apollo, we have a fantastic screening program for common cancers in India.
Right. Dr. Kumar, I would go over to you next. I wanted to understand by gynecological oncology, what do you mean? What are the kind of gynecological cancer that you usually come across? And how prevalent is cervical cancer among the lot?
Good afternoon, everyone. Thanks, Pratibha. Gynecological oncology is all about dealing cancers of the woman's reproductive system. I deal with the cancers of the vulva, vagina, cervix, uterus, tubes, and ovaries. Among all these, the most prevalent in India is cervical cancer. The incidence is around 20 per 100,000, and it's more common among low socioeconomic status. These are the people who have got no access to prevention, screening, and treatment. And very unfortunately, when they come to the hospital, they present at a very advanced stage. That's when they usually show up. And cervical cancers is a big social and economic burden to the entire country.
Right. So let me understand from you both, How do we identify these cancers? Dr. Bhavna, are there any symptoms by which one can identify breast cancer at its onset?
So I think it's very important that all women are at risk for developing breast cancer. And the statistics in the West are 1 in 5 will develop breast cancer, but I think the pattern in urban India is the same. So it's very likely to increase. Know what is normal for you. I think each one of us should stand in front of the mirror, self-examine our breasts, because some of us have lumpy breasts. One breast may be larger than the other. You stand in front of the mirror, you look at whether your nipples are symmetrical, whether the contour of the breast is symmetrical. So know what is normal for you. And when you know what is normal for you, if there is anything that you feel that the contour is different, there is dimpling of the skin, there is puckering of the skin, or the nipple is inverted, or there is any thickening that you can see, there is redness, or you can feel a lump, there is a nipple discharge, anything that is not the norm, you must go and see a specialist. One more thing I must say, that breast cancer usually presents with a painless lump, but there's a rare form of breast cancer called inflammatory breast cancer, which usually happens in younger women. It does not present with a lump. It just presents as if you have an infection. So again, very important, if you've gone through 2 courses of antibiotics, please seek a second opinion to make sure that we've ruled out breast cancer.
Right, thank you for that, Doctor. Dr. Kumar, are the symptoms similar in case of gynecological cancers also? Could you list out some of the symptoms for us? Is it easy to identify gynecological cancers?
Some of the cancers could be identified easily and some cannot be identified easily. And then these are the ones that come in and present at a very late stage. There are a few symptoms, but they are not all in common for all the varieties of gynecological cancers. So the lower part of the reproductive system usually share a common symptoms, like the vulval cancers, the vaginal cancers, and the cervical cancers. They usually present, vulval cancers usually present with a lump and with a bit of bleeding, and then ulcers, and then they're not healing over a period of time. Vaginal cancers and cervical cancers usually share symptomatology in the way that they usually present with bleeding through the vagina, bleeding after sexual intercourse. These are the most commonest symptoms which they usually present with. And most importantly, what every woman needs to know is it's not normal to have bleeding in between periods. Any bleeding in between periods or any bleeding after sexual intercourse, you need to get a gynecologist to examine you to see that there's no problem going on, whether it's in the vagina or the cervix. And cervical cancers, if they are very much advanced, they can present with different other symptoms. When they start obstructing the tubes that bring the urine from kidneys to the bladder, they get into kidney failure, and then they could even give some discharge. And endometrial cancers are the cancers of the lining of the womb. They usually present with bleeding. 90% of them usually show up with bleeding, and sometimes with a bit of discharge. Most notorious of all these type and most worrying with is the ovarian cancer, because the ovaries are normally a very small size. They've got a potential to grow up big and then spread into the abdomen. And unfortunately, most women who come and see me in the clinic are usually present when they're very advanced, and it's very difficult to diagnose very early. But there are ways you could you could get this screened and diagnosed, which I'm going to talk to you maybe in the later part.
Right, Dr. Kumar, you did mention some interesting points there about how bleeding presents in a lot of women who are suffering from any kind of gynecological cancer. So, at what stage do you think these symptoms manifest? Do they come to you at an early stage? Is there enough awareness about gynecological cancers in India?
It's very unfortunate. Coming to the most common variety is cervical cancer. I was trained in the UK, and it's not very common to see advanced cervical cancers there. There's a screening program, and then people get vaccinated as well. So you usually see them, and there's a screening program that's to pick up early and then to pick up precancerous changes. And unfortunately, I've not come across early cervical cancers as much when I came back last 2 years ago. And it is easy to pick them up if you're in a screening program, but it's difficult. When you start having symptoms, it means that they are getting advanced, and it is difficult.
Right. Dr. Bhavna, on that note, I would like to ask, if symptoms manifest on someone, uh, who should they seek help from?
So I would agree with Dr. Kumar that most of the patients that we see in our clinic, I would say even breast cancer, about 50 to 60% patients present late because we do not have a coordinated screening program. So I think if you have any of these symptoms, don't ignore. I think in India we have a attitude of complacency as well, where women do not prioritize their own health. They will always prioritize the health of their children, their husband, their family. So I've seen a lot of women in my clinic, they would have a lump in the neck or they would have a breast lump, which, for a long time. But they keep on thinking it's not hurting me, it's not causing any problem. I'll go during the holidays, and then the holidays they go on holiday. So, it's like, so they keep on postponing their own health. So I think it's very important that if you have any symptom, you must seek help from anyone. It could be your family physician, it could be your gynecologist, it could be an oncologist, it could be you like Apollo has a pro health screening program, so which is pro health. You could go to a preventive health checkup to any of the centers and get yourself checked up. But the key thing is, don't ignore. And if you're not happy, just take a second opinion. That's very important.
Right.
I would agree with you, Bhavna. This is very common. I've seen it happen culturally. Women put themselves last in the family dynamics, and they don't look after themselves. They have to feel that they have to be well to look after others. They put things to very last, and I've seen it happen very commonly as well.
Right, Dr. Kumar, that's one of the questions for you. Is it easy to detect any form of gynecological cancer in the early stage itself?
Yes, it is. It is very easy. If you see other parts of the world, usually the Western Europe and America, you see cervical cancers are 85% less when compared to other parts of the world, like third world countries. If you get into having vaccination, getting to have a screening program, getting to have regular health checks, you can pick cancers at a very early stage. If you're not seeing your gynecologist, not having regular health checks, not on a screening program, then things would be persistent for a while, and then you come in and see as an advanced stage.
Right, Dr. Bhavna, what are the screening mechanisms or screening procedures available for women to detect breast cancer at an early stage?
So I think screening is when you go for when you are well and you go for a health checkup. So for women, I would suggest having a mammogram at least once a year, once you turn 50, or at least every 2 years, and make sure you have a digital mammogram. So look for a facility which has a digital mammogram facility. So that is something which is evidence-based and should be done. Between the age of 45 and 50, now even in high income group countries, we are recommending doing a mammogram. I would suggest maybe every 2 years. In younger women, like I said, the incidence of breast cancer is almost a decade earlier in our country compared to the West. So maybe we should start screening at the age of 40. But I would recommend that you have a digital mammogram with digital breast tomosynthesis, which is again a type of a screening technique. As part of this, I'm part of this breast cancer for young women group in Europe, where we have recommended this to be done in younger women. The reason why we don't recommend a simple mammogram is because younger women have dense breasts. So you're very likely to miss any changes and give false reassurance. So that's why we recommend this. And if the suspicion is very high, I would suggest doing an ultrasound and an MRI of the breast as well.
Right. Dr. Kumar, are there any screening techniques available, the screening procedures available for cervical cancer or other forms of gynecological cancers as well?
Yes, there are screening programs for cervical cancer, but not for other gynecological cancers. But there are for ovarian cancer. If you're at a high risk, you get into the screening program. But unfortunately, we don't have a national screening program. So the people who have access to healthcare, finances, are the people who get the regular health checks and get into the screening program. And most importantly is the cervical cancer, which is more prevalent here. And it's common among low socioeconomic group because there's no access to screening, then vaccination, and then even to treatment and diagnosis as well. So that's very difficult. The way the screening program works here, it's not a national guidance as such, but it is given out by the Federation of Obstetrics and Gynecologists of India, the good clinical practice recommendations. It divides things into two ways. Somebody who's got access to finances and good resources, someone who doesn't have access to finances and good resources. The two ways it works out. It advises every woman above 25 who's been sexually active to get at least a smear test every 3 years. Or when we do the smear test, we look for the virus, which is the most, human papillomavirus is the one which causes cervical cancer in 90% of the cases. So we look for those which are at high risk. These are the high risk type of human papillomavirus we see. If they're having a test for the high risk HPV and the smear, then you could be spaced out every 5 years until you hit 65. If you're having a smear test done, it has to be every 3 years. If you're in a low resource setting, what happens is then you can have inspection of the neck of the womb, which is the cervix, with some vinegar-like solution called acetic acid. It usually picks up any precancerous lesions or cancerous lesions. And that happens every 3 years. So once you get into the program, early cancers could be detected and treated. Even precancerous changes, which it slowly goes through a pattern of abnormal cells, which are precancerous changes at a level of 1, 2, 3, and then progresses into cancer. So you could pick them up early at any time.
Right, Dr. Kumar, but how accessible are these tests for women, especially for women in rural India, where cervical cancer cases are, more prevalent?
It is not accessible, and I'm very unfortunate that that's the reason we see them in pre-advanced stage. I think it has to be a state guidance or a central guidance coming up to the primary health center saying, look, every woman needs to go through a visual inspection of cervix at least once or 2 to 3 years, and that will prevent most of it. If you see the West, 85% of the cancers have been prevented because of screening program, which is not actually happening in our part of the world. So I think 85%, which is, we see around 125,000 new cases a year in India, and then 60,000 of them die every year with cervical cancer. And that's what you're actually looking at, only the database that comes out. If you're in a rural part, you're diagnosed, then you may not get into the database. I think I'm just looking at maybe a set of a big proportion, maybe, which is not coming out.
Right.
So can I just add to that, Pratibha?
Yes, please.
So, sorry, Kumar, the government of India has actually launched a national cancer screening program, and that recommends from the age of 30, women can have a clinical breast exam every 5 years. And if there is any suspicion felt, they can go to the local community health center or district hospital, and an ultrasound can be done and a biopsy. And the similar thing, they've done it for 3 common cancers in India. They've done it for breast, cervix, the visual examination by acetic acid, and for head and neck cancers, because tobacco chewing, the smokeless tobacco, is very common in rural India and in urban India as well. So just a clinical exam of the mouth as well. So one contact with a healthcare worker, the thinking is, can possibly pick up these cancers early. So the key issue here is the implementation India-wide, how robust that is. And with COVID, I think that has taken a complete backseat.
Right, very important point that you're making, Dr. Bhawna. One thing I would like to understand is, what are the common risk factors for cancer in women? Would you like to talk about the breast cancer risk factors, Dr. Bhawna, first?
So the risk factors are, I see a lot of patients, they say, I'm a vegetarian, I exercise, I'm fit, I do puja, and, I lead a perfectly healthy life. Why did I get cancer? So risk factor doesn't mean that if you do all of these things, you will definitely not breast cancer. It means that, if you do all of these things, the likelihood of you developing breast cancer will go down significantly. So it's all about the genes and the environment. So genes, so I'll talk about, there are some lifestyle factors which may cause breast cancer. And there are some factors which you cannot change. So the risk factors that you cannot change are, being a lady, Getting older, as we get older, our chances of developing breast cancer increase. Inheriting some genes from your parents or your grandparents, family history of certain cancers like pancreas, ovary, prostate, and breast cancer, and also having a personal history of breast cancer. It increases your risk of developing cancer in the other breast. That's why, we do annual mammograms after the patient has had their treatment. Some being taller, having dense breasts. Again, the thinking is if you have dense breasts, probably you miss these areas sometimes. Having early periods and a late menarche, after the age of 55, because the exposure to hormone is longer, increases your risk. Lifestyle related factors which are completely modifiable. By that I mean is, it's completely in your hands, that you can do all of these things and bring down the risk by almost 50%. Regular exercise, physical weight, even if you do a moderate amount of brisk walking, the risk reduction could be up to 25 to 40% in some studies. Not having alcohol, tobacco, so one of the other risk factors is not having children, no feeding, no breastfeeding, or having a shorter duration of breastfeeding. Using oral contraceptive pills or hormone replacement therapy for a long time. Again, we've learned after doing a lot of clinical trials that if you use them for less than 4 years, or if you use an estrogen only pill, that is safe. And also, I just wanted to briefly mention about implants. The textured implants don't increase the risk of your breast cancer, but it increases the risk of developing a very rare type of lymphoma within the breast. So, you should be mindful of that as well if you have an implant. And also there are certain unclear messages, vitamins, whether there's a possible link between high fat, low fat diet and breast cancer. So there are some studies which have shown that if you have a low fat diet, it decreases the risk of breast cancer. But if you have a diet which is high in fruits and vegetables and calcium-rich dairy products, but low in red meat and processed meat, it decreases your risk of developing breast cancer. But I must say that remains an area of research.
Right. Thank you for that very detailed explanation, Dr. Bhavna. Dr. Kumar, I also wanted to ask you the same questions about the risk factors that are involved in the gynecological cancers among women. Are these the same risk factors, or do they vary in cases of gynecological cancer?
They do actually vary depending on the type of cancer you have.
Right.
But vulval cancers and cervical cancers share a bit of common risk factor, which is usually and most of the times caused by human papillomavirus, and vaginal cancers as well. These three more or less share the same risk factors as such. But I'd rather stick on to the three most commonest is the cervical, endometrium, and ovarian. So coming to the risk factors of cervical cancer, most importantly is not having vaccination. If you're vaccinated, you're protected at least 70-75. So, but you still have, even though you have vaccine, you still need to be screened. The second thing is sexually active at a very early age, with unprotected actually without condoms, because this is usually caused by human papillomavirus, which is a sexually transmitted infection and is present in 90% of the women who are sexually active. So, and then smoking decreases the immunity, and then it's got carcinogenic properties as well. And then somebody who's on pills or contraceptive pills, they feel that it is a form of contraception and never use condoms, so that's a risk factor as such. And then having multiple sexual partners. So if you've, and then you might infect different varieties of viruses with a different partner. So these are the most common risk factors for cervical cancer. And endometrial cancers are very different. They usually happen for women who are menopausal, means somebody who's finished having their periods, and somebody who's actually obese. And there's a little contribution from a family history as well. Somebody who's got a family history of having endometrial cancers, and somebody in your family who's had history of bowel cancer, ovarian cancer, pancreatic cancers, colon cancers. These are the ones who actually share the common problems, which are inherited ones in endometrial cancers. And somebody who's got PCOS is at a high risk of developing endometrial cancer. and somebody who's been on a hormone replacement therapy after menopause, or somebody who's been on a drug called tamoxifen for breast cancer. These are risk factors for endometrial cancers. And obesity is a big thing in endometrial cancer. It is twice as common for somebody who's got a BMI between 25 to 30. From 30 to 35, it is 3 times common. And from 35 to 40, it is 4 times common. Above 40, it is 9 times common. So that's how obesity and endometrial cancers, it's related to lifestyle. And once you get your weight, cut your weight back, then things would just revert back to normal. And somebody who's got abnormal bleeding after 40 years of age needs to get their lining of the womb tested to see that there's nothing abnormal going on. These are the few risk factors for endometrial cancers. Coming to ovarian cancer. Ovarian cancer, as such, the most important and great proportionate of it is familial risk. Somebody's inherited a mutation. These are called, I think Dr. Bhawna will talk a bit more about it, they are BRCA1 and 2 mutations. These are tumor suppressor genes in some of the chromosomes in the body. When there's mutation on them, you're prone to developing breast and ovarian cancer. So this gets around 15 to 20% of the ovarian cancers. Others are just sporadic. It's very unfortunate they usually develop.
Right. Thank you, doctor. That was one of the questions that I intended to ask Dr. Bhavna. Do genetics play a role in these cancers? If somebody has a family history of cancer, are they more susceptible to breast cancer or other forms of cancer?
So yes, about 5 to 10% of patients have a hereditary breast cancer, and there is a genetic component involved with it. And there are certain genes which are labeled as the breast cancer, BRCA1 and 2 gene and PALB2. There are some genes with what we call less penetrance or moderate penetrance with BRCA1 and 2. The lifetime risk of a lady developing breast cancer, if they carry this gene, is almost 80%. But there are a lot of strategies one can do to mitigate these actually. One can do what we call drug pharmacoprevention. There's a drug called tamoxifen or aloxifen, which can be given to decrease the risk. There is a risk reducing removal of the breast or mastectomy, because if you remove the risk factor, which is the breast, and remove the ovaries, then the risk automatically goes down. I think Angelina Jolie had made this very famous. Actually, I was in India that time, and every single patient who walked in through my door, in fact, I did a meeting in Chandigarh, I remember, with 200 doctors about cancer prevention, and nobody wanted to talk about cancer prevention. All they wanted to talk about, should we get everybody BRCA tested? So that's another debate. So when I wrote a piece on, personal choice, but a public impact on her decision. So I think this is, but it is very rare. But women who do have it need to be screened a decade earlier than their mother or grandmother when they develop breast cancer. And usually the modality of screening we recommend is an MRI of the breast, because it's usually younger women, and also a transvaginal ultrasound to look at the ovaries, because the risk of ovarian cancer is high as well, and a marker in the blood called CA125.
Right. We always talk about screening for women, to identify cancer at an earlier stage itself. And most experts agree that, if you detect at an earlier stage, the chances of recovery and the outcomes are better. At what age should a woman start screening for cancer, at the new age? We always talk about, how women, more and more younger women are getting cancer these days. So what are your recommendations on that, Dr. Sirohi?
So I would say, you should know your body, what is normal for you. And, if you're having periods, and if you're having periods should happen every 4 weeks, if you're getting that in 2 weeks time, if the periods are heavy or anything which is abnormal, you've examined your breast and you can feel a lump. No age is immune to developing any type of cancer. And breast cancer as well, because being a lady itself, I think, is a risk factor. So don't ignore anything that is unusual for you, and seek help and advice. As far as screening is concerned, if you are at high risk, then yes, I would recommend these tests which we talked about. But if you're at an average risk, like most of us are in the community, where we may have one family member who had breast cancer in their 70s, 80s, that does not count as family history actually. So I would just start screening from the age of 45. But before that, just be mindful of symptoms and, go for a health checkup at least once a year. We are seeing a lot of hypertension, diabetes, anemia. There are other problems as well which can be diagnosed and treated early. A lot of high cholesterol being seen in the younger population. So you must look after all of the other things as well.
Right. Dr. Kumar, is surgery the most obvious treatment modality discussed in cases of gynecological cancers?
It depends on the type of gynecological cancer where surgery plays a role.
Mhm.
It's for early cancers in the cervix and cervical cancers, when they usually present very early, could be treated surgically. So then they wouldn't need any additional treatment in the form of radiotherapy or chemotherapy. But if they come advanced, then they need either form of chemoradiotherapy or pure chemotherapy. If it's getting pure chemotherapy, then you're doing it for a very palliative intent in the way that just trying to get more days on. So with endometrial cancers, they usually grade in a way that usually symptomatic. They present with bleeding. 90% of them usually have bleeding, and most of the women around with endometrial cancers usually are symptomatic, and it means that they're present early. So yeah, and that could be treated surgically. Even advanced ones need surgical treatment in endometrial cancer. Then chemotherapy comes in a bit of a role. But unfortunately, ovarian cancer presents late, and two forms of treatment modality comes in when they are advanced. One is surgery, another one is chemotherapy. They need both modalities of treatment, both surgery and chemotherapy. Depends on if it is too advanced and is present everywhere, then we give chemotherapy first and then operate next, and then give chemotherapy after we do the operation.
Right. I wanted to ask you a little bit more about that. Dr. Bhavna, at what stage does chemotherapy become essential in the treatment of cancer? How do you reassure patients about the side effects of chemotherapy? I would like you also to answer it, Dr. Kumar. I'll ask Dr. Bhavna to go first then.
So I think it's always patient choice. When we have a discussion about chemotherapy or any treatment modality with a patient, it's a shared decision making. You discuss the risks and the benefits of the treatment. If the risks are very high and the benefits are less, then you don't go for it. But if the benefits are high, then you would take the risk. But at the end of the day, it's all about patient choice, whether they would want to proceed with the chemotherapy. So it's never essential. We look at certain things within the cancer. We look at how fast the cells are dividing. It's called the grade of the cancer. We look at what the size of the cancer is. We look at how many lymph nodes, if they have been removed, are involved. We look at what the receptor status is. For breast cancer, we look at estrogen receptor and HER2 receptor. And then we individualize the treatment. Sometimes we also do the genomic assays, where we look deep inside the tumor to see whether the patient will actually benefit from chemotherapy or not. Because the genomic assays sometimes tell us that the benefit of chemotherapy is going to be almost nil or minimal. So then, you would not recommend that treatment. But if the patient has one or two or more risk factors, then, we would recommend chemotherapy. And I normally show the patient a graph or a diagram where I show patients that exactly what the percentage of benefit will be, because it helps them decide whether they want to take that benefit or not, whether the benefit is 5%, 2%, or 30%. So, that helps them in the decision making when they see it visually on the computer that, the benefit is quite high. And the risks are there as well with chemotherapy, because all drugs have side effects. As far as how I reassure patients about side effects, I would say that we have become better over the years at treating patients. None of my patients have nausea or vomiting now. It's a rare occurrence. It used to be very common when I started training. Very few patients get admitted with infection because, again, we've got the dose intensity right. We have growth factors available which decrease the risk of developing an infection. We have things like scalp cooling, which decrease the chances of ladies losing their hair. So 50 to 60% of patients would actually keep their hair while on chemotherapy, which is a big thing for us, is to undergo a mastectomy and then lose the hair. So, but the other thing is, even if scalp cooling is not available, it's not a big deal because one can go for wigs. Most of the side effects with chemotherapy are reversible. So, so that is the biggest reassurance. And there are some things which I tell patients, hydration, nutrition, hygiene, and exercise. If one does all four of these things, then usually I've seen, and having a positive attitude also, I feel sometimes helps. I've had patients who've not given up a single day's work while undergoing chemotherapy. And I think it's just to do with mental grit and their spirit that they are able to do it.
Wonderful. Dr. Kumar, would you like to add to that?
I'd leave it to Dr. Sirohi because she deals with chemotherapy more than I'm actually a surgeon. But
Right.
in our gynecologic malignancy, it's usually indicated if it's in an aggressive variety or an advanced stage. That's when chemotherapy comes into play. And I deliver chemotherapy on the advice of oncologists only at the time of operation for advanced ovarian cancer. We give heated chemotherapy for a while to kill cancer cells after we take all the cancer out from the abdomen in advanced ovarian cancer. That's the only time I deliver chemotherapy.
Right. Dr. Kumar, how much of tissue or organ conservation is possible during surgeries these days?
We tend to be less aggressive and more aggressive as well, I'd say. So less aggressive means somebody we do fertility preserving options and we do radical operations. So depending on the choice and what stage in their life they are, and if it's advanced, then depends on what type of cancer and all are. So we tend to be very less aggressive and give more to quality of life, but we have to get the balance right between the quantity of life we give with the quality of life they have. So that is how it depends. It depends on the stage which they present, and then whether surgically it's feasible to do the operation or not, whether they are operable or not. Coming to cervical cancers, we do operations only for very early stage or something that's persistent despite having chemotherapy or radiotherapy, but that's only for very advanced. Those patients, they don't have quality of life because the cervix is sitting very next to the bladder and to the bowel. So at that time, you would end up having a bowel bag or a bag that's producing urine from the tummy. So these are not quality of life indicators as such. Then they have more aggressive surgery. So endometrial cancers usually the same. Very early don't have much radical surgery, but late stages we give chemotherapy and then operate and treat the same way like how we treat the ovarian cancers. Ovarian cancers as such, some of them could usually present with large cyst and they could be very early. If that's the case, then we tend to be less radical, given the fact that if they wanted to preserve the next ovary and have children, that's when we just take the ovary out, leave the womb and the next tube and ovary, and then do what's called a staging procedure to see whether it's spread to other organs in the tummy. If that's the case, then we could be less radical. But unfortunately, in ovarian cancer, you can't be. The intention is not to leave any cancer at all that's visible to the naked eye. So we tend to be more radical in ovarian cancer. And usually 75% of them usually present very advanced.
Right. Dr. Bhavna, I would like to understand from you, there are many specialized treatment options available for patients with cancer these days, like brachytherapy, immunotherapy is being discussed. What are the advantages of proton therapy and how does it improve the treatment outcomes?
So as far as immunotherapy in breast cancer is concerned, I don't think it's currently the standard of care because there is controversy. There was a new trial which was recently published, which shows that the data was not as amazing as we thought it was. So I think we need to still do more research to be able to understand that, whether it really works in patients with triple negative breast cancer. 15 to 20% of our patients have that. As far as proton therapy is concerned, I think we talked about giving patients smarter and kinder treatments. So what we are trying to do is de-escalate treatment and make the treatments more accurate and safer. So as far as radiation is concerned, we used to give 6 weeks, 5 to 6 weeks of radiotherapy for breast cancer. Now we give 3 weeks or 1 week of radiotherapy. There is one trial which showed the fast forward study that maybe some patients need only 1 week of radiotherapy. They don't need to come for 3 weeks. Proton therapy is also a type of radiation where, you know, I'm not a radiation oncologist, by the way. I am a medical oncologist, but I know what it does. It gives safer radiotherapy and is more accurate. And the main aim is to actually protect the organs surrounding, like heart and the lungs. So the dose to the heart and lungs is less, because as we are curing patients, our patients are living longer. So what we want is, you know, 20 years later, they do not have a cardiac event.
Right. Thank you, Doctor. We are also receiving a lot of questions from our audiences. Since you have to leave a little early, I would like to pose some of these questions to you.
Sure.
So there is a question from Ms. Priyambada. She's asking, aren't the risks of breast cancer, in fact, the reasons for reduced incidence of cervical cancer and vice versa? So what would be the ideal birth spacing and the number of pregnancies to keep the risks of both at a minimum?
So again, you know, you are absolutely right. In India, what we are seeing that infection-related cancers like cervical cancer and stomach cancer is related to a bacteria, Helicobacter pylori. So the incidence of these is going down, but lifestyle-related cancers, which is urbanization of India, you know, 80% of India used to live in villages, now it's 65%. So the urbanization has meant that the incidence of cancers like breast cancer and colon cancer is going up. So I think have late marriages. Again, there is no research to say when you should get married. I think this is a very personal choice and a personal decision. But I would say mid-20s, late 20s, and you know, there are some studies that if you have children late, the incidence of problems in the child are also there. So maybe completing your family before the age of before early 30s would be ideal, and breastfeeding for at least 6 months, but up to a year is recommended.
Right. Another question that we have. Oh, yes. Dr. Kumar, you wanted to add?
I would add to it as well, because
Please.
fertility becomes an issue. You can't get pregnant now. It gets very difficult to get pregnant after 35, and when you hit 40, the chance of you miscarrying, having problems during pregnancy and all will increase. So I usually advise women, get your family sorted out before 35.
All right. Dr. Bhavna, I have another question from Priya. How do you propose the screening process can be mandated in India?
So like I said, the government has made a fantastic start in late 2016. It got started, implemented in 2017-18, if I'm right. Ayushman Bharat is PMJ. All of these, I think, are fantastic initiatives which are truly making a difference, and we will see the results hopefully in the next few years' time. I think what they should mandate is, you know, Australia has been able to get rid of cervical cancer as a problem. We've got rid of polio. It's an infection related. I think we should put cervical cancer vaccine as part of the national immunization schedule, because that would help eliminate cervical cancer as a problem. And it's a big drive from WHO as well to do that as part of their SDGs. I think we need to invest more in health. The GDP that goes into our health sector has to increase. That would be my submission, and I know it will happen slowly with time.
Right. Dr. Kumar, you wanted to add to it?
No. I think Dr. Bhawna.
Okay. Doctor, before you go, I have one more question that I would like you to answer. This is from Ms. Sudarshana Bose. The habit of getting a routine pap smear isn't that prevalent in India. Is there anything that can be done to raise enough awareness about the benefits of early detection?
So I think again, what you're doing, I'm very grateful to Times of India for doing this. That, you know, this helps raise awareness. It helps create a conversation, and then, you know, one person talks to 20. Each one of us will have at least 50 people within a circle that we will talk about. I think raising awareness is the key in getting, and you know, everybody in your circle, try and get them have an HPV DNA test, you know, which needs to be done every 5 years. And I mean, we don't live in a country which has universal health coverage, so we have to drive it ourselves. You know, pap smear has to be done every 3 years. Dr. Kumar will talk to you. And again, it's a very simple, cost-effective test. and we should try and push for it actually.
Right, Dr. Kumar, you wanted to add to it, how can it benefit, what kind of benefits will it have in the early detection of cervical cancer?
Because you could see if there's any progression to cancer, and then precancerous changes could be detected and they could be treated. If you get a treatment for a precancerous change, then it's 98% cured. Then you get onto a regular screening program. So that gets you an advantage of detecting cancers early and then diagnosing the precancerous changes, which would probably turn into cancer in the future.
So these 4 cancers, cervical cancer, breast cancer, colon cancer, head and neck cancer can be treated at stage 0, at precancerous stages. So that's why they lend themselves to screening. And this is something, we should drive within our communities, within our RWAs, within our social circles, and push for it. Even if a woman has one pap smear in her lifetime, that also will help in decreasing the incidence of cervical cancer.
Yes, doctor, also, our discussion is broadly on the cancer in women. And as we have seen, the number of cases of breast cancer is rising in India. So what would be your general advice to women who are watching this webinar and parents of young children, young girls especially?
So I think just follow the 60% of cancers are preventable in India. I always talk about the ABCs of cancer prevention: avoid alcohol, tobacco, oral pills, and hormone replacement therapy, oral contraceptive pill. Be breast aware and breastfeed. B is for that. C is calm, meditation. Calm is very important because stress is implicated in a lot of factors. D is diet. Have a diet which is varied and healthy, has lots of fruits and vegetables. Be active. E is for exercise. F, know your family history. S is for sleep and screening. So inculcate this in your lifestyle. Be disciplined about it. Be proactive about your own health. I think women should be proactive about their own health. Gift your mother or a grandmother a mammogram on their birthday, rather than spending it on anything else, because I think that will be the best gift you could give to your loved one.
That's a very sound advice from you, Dr. Bhawna. I'll let you go right now because you have other sessions which are lined up for you.
Thank you so much. Thank you.
Thank you.
Thank you, Bhawna.
Bye-bye. Bye. Thanks.
Dr. Kumar, we'll continue our discussion on gynecological cancers. So I wanted to ask you, what is the efficacy rate of vaccines? We know that there is a cervical cancer vaccine which is available in the, for preventing cancer. Are vaccines available for other form of gynecological cancers as well? And could you tell us about the efficacy rates?
The vaccines are against high-risk human papillomavirus. The most commonest among them is what causes 70% of them is 16 and 18. There are hundreds of them, but 40 of them usually causes these anogenital problems. So among the 40, the most high-risk ones are 16 and 18. They're called bivalent, means trying to vaccinate against 2 human papillomavirus. Next is 11, 16, 6, 11, 16, and 18. That's called quadrivalent. So you're targeting against 4. There's nano, which is against 9. So that's against 6, 11, 16, 18, 31, 32, 45, 53, something like that. So these are, but from 16, 18 to increasing it to 4 and 9, there's only a slight change in, and then usually protect you for around 70 to 75%. You're protected, but you still have a vaccine. You need to get into the screening program because you're still a 25% chance that you could develop cervical cancer in the lifetime. But once you get into the screening program, you're 85% prevented from developing a cancer. So you're getting more benefit from having vaccination. HPV vaccine doesn't just protect against cervical cancer, because the same virus they cause vaginal cancers as well. At the same time, they cause vulval cancers. They're involved in it, and anogenital area, the anal cancers, and some proportion of them can cause oral cancers. So you're having a HPV vaccine, you're protected against cervical cancer the most. Next is the vaginal cancer, next is the vulval cancer, then it's around the anal area, and then even the oral cancers, which are HPV related. So around 70 to 80, you're protected. get onto the screening program, you're 85% screened.
Right. Doctor, I wanted to ask you, when somebody is detected with cancer, when somebody presents with cancer symptoms, women often get, women are scared, there is a fear about cancer among people who are affected by cancer. So what are what do you have to say about the outcomes, treatment outcomes these days, and how are they improving the quality of life of women these days?
Things have changed and moved on, right from what you give for fertility to what you give for quality of life. All this putting at no compromise in the longevity you give. For cervical cancers, somebody's not had children and had a very early stage cervical cancer, we could still do an operation called a trachelectomy, which we take only the neck of the womb, the cervix, with tissues around it and the top of the vagina. And the woman still could get pregnant. And no compromise in with the survivals. So there are ways we could just help them that way in surgery for cervical cancer. Same thing with ovarian cancer. If someone presents with very early stage, then you could just take only the tube and ovary on that side and then see whether there's any spread elsewhere. And if there's no spread, then they could still retain the other ovary, and then we keep monitoring them to be sure that they're not developing any recurrence. So that way things have moved on and evolved. And the same thing with endometrial cancers as well. If somebody's got a very early endometrial cancer with precancerous changes, you could still treat it medically, keeping the womb intact by giving some a hormone releasing coil, which will thin out the endometrium. And then these changes are to revert to normal, and we keep monitoring it. And then she can get pregnant. So there have been changes this way, being less conservative, and then at the same time being more radical as well. Say endometrial cancers, when they were presenting very advanced, there wasn't much evidence to say that you could be more radical in doing, but now the evidence suggests that you have to go in and take all the cancer out and then give chemotherapy, or give chemotherapy first and then take the cancer out next. Same thing with ovarian cancer, you're more radical. So previously, when the survivals were around 15-20%, 5 years, that's what we talk in all cancer, that which women survive for 5 years with this type of cancers. But things have moved on. The surgical approach has changed in ovarian cancer. Used to be less radical, now we are more and more radical. What we call a optimal surgery was only if you leave a centimeter of a cancer visible to the naked eye. But what's called an optimal surgery is nothing visible to the naked eye. You want to leave no cancer that's visible to the naked eye for more chemotherapy to act. That's when women live longer. And then we're now able to give 40 to 50% 5-year survival results. So things have moved on, and with the way and the approach as well. Like usually cancer spreads locally within the organ itself, or they either take a bloodstream or a lymph stream and then spreads to the other parts of the body. So what we've come in recently, because when I was talking about, I'll have to look at the places to see at the early stages where the cancer has spread or not. What we first look at is called the lymph glands. Lymph glands are the organs which are very protective in the body. If you have a sore throat, you have a swelling on the neck. These are the organs that make sure that they take the infection or the cancer to themselves and then make sure it doesn't spread to elsewhere. So we usually what's called staging when we're doing an operation for cancer. So now and then we take most of the lymph nodes out. There are problems in taking all the lymph glands out, like the swelling of the leg, your damage to the other organs surrounding it. There are complications. So what we've now come across is for very early cancers, what we call the sentinel lymph node. We use a dye and then use a near-infrared cameras, and we just take out the first draining lymph nodes. That's most commonly used, and that's where most commonly in breast cancer. Now we move to vulval cancers, cervical and endometrial cancers as well. So from less radical, more radical, minimal. So all things have moved on and changed now.
Right. Doctor, have you ever come across cases where, multiple reproductive organs have been affected by cancer, and how common are these conditions?
Unfortunately, if someone is finished having or finished childbearing, then if they have a gynecological cancer, whether it's from the endometrium, because they're all hormone dependent, that's when we take all the pelvic organs out, especially the reproductive organs. What I meant was female reproductive organs. And it's the same thing happens with the ovarian cancer. They can be hormone receptor positive. So we tend to end up taking the uterus, the other tube and ovary as well, if it's confined to one. But if somebody wants to have babies, then we leave it. So most of the times in gynae malignancies, you would end up taking most of the pelvic organs out for somebody who's beyond 40, 45. Okay, and it's at an early stage. But if it's an advanced stage, we tend to take tubes, ovaries, everything out. But we tend to save the hormonal function for somebody early cervical cancer. What we do is we take the ovaries out, hitch them up to the sides of the tummy if they have to have radiation. That's called ovarian transposition. We still preserve ovarian function. Ovaries are needed not just for reproductive function. They protect you from the heart disease. They protect you from the bone problems, mood issues, and even so many, it's womanness and reproductive function and sexual function as well. We tend to be more and more conservative. When it needs saving it, we save it. When it needs coming out for any obvious reason that would affect our life, and that's when we recommend that we need to take the pelvic organs out.
Right. Doctor, what are the latest technologies available in the treatment of cancer?
One thing I've mentioned to you about is the sentinel nodes, where we tend to be less conservative in it. And then I've talked about fertility preserving options, which have come up. And then nerve preserving options, we use laparoscope and robotic procedures where we look at high magnification, make sure that there's no nerve damage done, which supplies the vaginal bladder and the bowel, making sure that the function is well preserved. And then with the minimal access surgery has evolved so much in the last 15 to 20 years. And then now with the advent of robot in the last 10 years, things have moved on from traditional open surgeries for early cancers to laparoscopic surgery and robotic surgery, where women could just walk out of the hospital the same day or the next day, and then back to life in a week's time. So these are the very few surgical advances that's happened when it comes to being less aggressive. But I've told you about being more aggressive, which could give her more life, especially in ovarian cancer, where we end up spreading it everywhere in the abdomen. We end up taking organs involved in it, making sure we don't compromise any quality of life at all.
Right. Doctor, you did mention minimally invasive procedures, and you did mention robotic surgery as well. So what are the applications of robotic surgery, especially when it comes to gynecological cancers?
Robotic surgery and minimal access surgery or laparoscopic or keyhole operations are usually used mainly in endometrial cancers, and then for non-cancerous work as well, or ovarian cysts, which are confined. Any ovarian disease confined to itself, and they are not big. There's no disease outside the cyst or endometrial cancers or the cancer of the uterus, and these are the main role. And cervical cancers, things have moved on from minimally invasive to open. There's a contradictory evidence about what access you need to be using. America, Canada, and other parts of Europe have stopped doing keyhole operations for cervical cancer. It is, if you do it, you have to do it on the agreement of the patient and your own results as well. So it is not a gold standard practice at the moment, but we still do it to take the lymph glands out and then can proceed it. We do it like a joint procedure, saying a woman having a big up and down cut rather than giving a tiny bikini line cut. So, and then the advances and advantages are you can use a sentinel node on the robotic platform, which means that you radiolucent dye and then you look at and take lymph glands out. With all this, patients can walk out the next day. They're tiny little cuts around less than a centimeter actually, and then they're very up and mobile the same day, and then eat and drink the same day, then walk out of the hospital the next day. And then the complications are lesser, like the wound infection. And then with the robots, you have dexterity is so much that you can't get it on a straight stick. So the number of complications have decreased with the new advent of robotic surgery. But it helped surgeons moving from open to robotic surgery. If you want to be a robotic surgeon and you've been open surgery and you've got no exposure doing minimal access surgery for your patients, it takes only 20 procedures to master a robotic surgery. And it's proven to be safe and very safe for the last 10 to 15 years. But to train yourself to be a laparoscopic surgeon, you need at least 80 to 100 procedures, and the learning curve is very steep. So it's easy to move on from open to robotics, and then for a laparoscopic surgeon, it's pretty much easy. I think you can master it in 10 surgeries. So helping women to recover faster, less complications, and then with equal results as such, and then having decent quality of life, and then back to work and life in no time. So that's the greatest advantage with minimally invasive surgery these days.
Right. Thank you for explaining that in so much of detail, Dr. Kumar. My next question is, what should patients look for in a healthcare center, and what impact does it have in their treatment and the outcomes?
I would want any patient who's diagnosed with a cancer to approach a cancer center or a cancer hospital. See, if an individual or a patient comes in, I don't treat as an individual. We are here as a team, and we have all facilities under one roof. Whoever comes into a hospital, decisions are provisionally taken by me, and then I present it to a tumor board where groups of clinicians sitting together, the surgeon, the pathologist, the radiologist, the radiation oncologist, specialists, nurses, everybody sit together, and then I give a complete picture of the patient's condition, concerns, issues to address, and then we jointly are responsible as a center to look after them. So, and we are all subspecialized. I would want somebody who do the work every day rather than doing it on and off, and we update ourselves in cancer work when we are very organ specific. I would recommend women to go see a cancer surgeon who does the work day in and out and get support from all aspects and take an organizational responsibility, and where you could get everybody under one roof and be responsible for your care.
Right, doctor, thank you so much for explaining that. We have a lot of questions coming in from our viewers. A lot of them asking specifically about cervical cancer. So let me begin with this question. Can you tell us about the symptoms of cervical cancer? We did cover this a little while ago, but could you please repeat it for the benefit of our viewers who are just logged in?
Most commonest symptom of women present with cervical cancer is bleeding after sexual intercourse. That is the most commonest symptom. Somebody has got bleeding after intercourse, you need to go check by your gynecologist to be sure that there's nothing abnormal sitting on the cervix or on the vagina. Second thing is bleeding in between periods. It's not normal to bleed in between periods. And if you're having bleeding in between periods, you need to go see your doctors. But others, these are the most commonest symptoms, are persistent vaginal discharge, and it's not subsiding. So you need to get yourself checked whether it's an infection or whether it's a cancer. But other symptoms are pertaining to advanced cancers and we see very, very few of them. These are the most common symptoms you see.
Right. Doctor, another question that I have from Ms. Shahina, is there any age limit for taking vaccination for cervical cancer? Cervical cancer vaccines are available. Is there an age limit for women?
The usual recommendation is before 16 or you're sexually active. There's no age limit as such, but you wouldn't be protected once you become sexually active because you might get most of the strains of HPV, and it is 90% common. If you've now been sexually active, till 40, there's no age limit, but the usual recommendation is, and then your spacing changes, but as a recommendation, we would want to do it before 16, before a woman gets sexually active. But as long as you're not being sexually active, you're usually protected. But
right. Doctor, there is another question from Mr. Vaibhav. He asks, we've read in the internet about people with certain health conditions running a higher risk of getting certain diseases like diabetes, for example, or heart attacks. Similarly, are there any risks? Is there a higher risk for people with any specific health condition to get gynecological or cervical cancer? Basically, they're asking about the risk factors for cervical cancer and gynecological cancer. We did cover this also, but do you want to explain it once again? No,
I think somebody was asked this question is wanting to relate it to something related to any general health conditions rather than its own risk factors itself. There's no general health condition that gets somebody more prone to cervical cancer.
All right.
But endometrial cancers usually happen in obese individuals where they usually present with diabetes, high blood pressure, cardiac issues. So it's somebody who's morbidly obese, and that's go hand in hand, but nothing with ovarian cancer. I would relate it only to endometrial cancer with general health conditions. It's a coexistence with other problems that you're getting with it as well.
Right, but PCOS does seem to be a risk factor.
PCOS itself is a risk factor. The way how PCOS works is because women don't ovulate and they don't have regular periods when it comes to polycystic ovaries. The way, because when there are no periods are to be regular and usually happen between 28 to 32 days, between average of women, 28 to 30 days. If they're not happening regularly, you need to see a doctor. Why is it not happening? There are several ways where you don't have periods might be spaced out, but most commonest is PCOS. You see it's in 1 in 6 to 7 women. It is that common. And the way we diagnose it is irregular periods, having more testosterone-related issues on the body, like more facial hair, acne, and obese individuals as well. You see it. And then when you don't ovulate regularly, and then there's more stimulus with the estrogen, is the type of hormone that's secreted from the ovaries. And then you don't stretch your lining of the womb. That's how a period happens. So it keeps accumulating layer by layer, and these are more prone to developing. So you end up having precancerous changes and then develop into cancer. So I recommend women with PCOS to go see a gynecologist, and they should have a withdrawal bleed every 3 to 4 months, which we give hormone tablets for them to bleed. And then lifestyle modifications. You cut 1/6 of your body weight, your periods might get back to normal. Being obese itself will get you to hormonal imbalance, and then you're prone to developing endometrial problems. So, and these are the ways you could handle PCOS and then get a regular withdrawal bleed, and then you're not more prone to developing endometrial problems.
Yes, doctor, that's one of the questions I also had. We all often talk about lifestyle modifications. What are the kind of lifestyle modification that one can bring about to, reduce the risk of cancer?
I'd stick on to gynecological cancers. I mean, lifestyle modifications with regard to cervical cancers, we'll talk about smoking. Condoms helps if you're not with a regular partner. So that helps preventing you from cervical cancers. And OC pills, even if you're using OC pills, using it as a birth control, but if you're with a different partner, I would rather advise you to go back to using barrier methods where you could prevent yourself from having another strain of HPV, human papillomavirus. And with endometrial cancers, it's a significant thing as well, like obesity, weight loss, exercise, healthy diet would help prevent you from having endometrial cancers. There's nothing with related to ovarian cancers such with lifestyle modifications you could do.
All right, doctor, how accessible is gynecological cancer healthcare, especially in rural areas in India?
In rural areas, I mean, usual setup is you have 1 or 2 doctors, and they may not be all trained in gynecological problems. So you have to get to a specialist center. I think all specialist centers are only centered to towns and cities. So it's obviously there's always a issue of, yes, everybody would address and escalate it to the next level, but having an expert locally available would make difference.
Right.
Which commonly happens in the cities, right? You want a gynecologist, you get it. You want an endocrinologist, you get it. But that access is not there in the rural population, where you have most of the times not specialists, but generalists. And then there's always a difference you could get from a specialist than a generalist, right? So that's what I feel is all about. And awareness, screening, education.
Right. Doctor, another question that we have is, are very young girls, in their teens especially, are they susceptible to any form of gynecological cancer, and how common are these?
What I see in young girls is probably a variety of ovarian tumors, ovarian cancer. They usually happen what's called something related to, these are all germline type of cancers, which usually happen at a young age. Very rarely you see what's called a borderline tumors, which is not cancerous, but got a potential to develop locally. But they don't use the lymph stream or the bloodstream. They're in between. Something that's grows normally and grows abnormally is what we call benign. Normal but abnormally growing. Abnormally growing, abnormal tissue could be cancerous. Okay, within which between normal and abnormal there's something called borderline. These are very common in very young individuals. I've operated on 13-year-old, 14-year-old, 15-year-old, but the most commonest is the rarest of the varieties, which is germline varieties. Yes.
Right.
They're not very common. They're only 5%.
Okay, they're not very common. Good. Doctor, we have come to the end of our questions right now. So before we wrap up this session, I have one more question to you. One key takeaway from the session, on debunking the myths related to cancer and, talking about cancer in women, is that cancer is curable. What else would you like to tell women who are living with cancer right now?
I'll address your first question, which is what you should be doing, what message I want to convey.
Yes.
First thing is vaccination. So if you get vaccine, you're seeing an incidence of 125,000 per year. If you're cutting it down by 80%, you're almost seeing only 10, 15,000 cervical cancers in the next few years. That's first thing. Next thing is screening. You have to get screened. You have to get into a screening program. Or if you're in a rural part of the country, go to your PHC, get a visual inspection of your cervix with acetic acid. If you're in an urban population, access to a gynecologist, get into a screening program. Go tell your gynecologist, I want to have a smear test done every 3 years, or which is called, I said, HPV testing and all, which is co-testing. It's every 5 years. And if you got somebody in your family who's diagnosed with breast or ovarian cancer, go see a gynecologist or any other physician and get to see your risk factors for ovarian cancer, whether you need anything. And somebody with an ovarian cancer in the family, find out whether they've had the BRCA testing. Now, the recommendation is that every woman who's diagnosed with ovarian cancer needs to have gene testing with BRCA. That will tell you whether others in the family are prone to it. There's 50% chance that if my mom's was BRCA positive, I'd be 50 chance that I'd be BRCA positive. That's how it needs to be looked. So addressing your risk factors, someone with uterine cancers, someone with obesity, cut your weight down, please. And then you'd get your diabetes down, your hypertension down, your endometrial cancer down, heart disease down. You'll be better off. You'll have a different life with all less risk factors. With PCOS, go see a doctor. It's not the end of the world. You could still get pregnant, have your withdrawal bleeds, okay? You can stimulate your ovaries to have your ovulation. You could still have babies. Most importantly is to have no problems in the lining of the uterus, which will develop into endometrial thickness increasing, which you call a hyperplasia, and then later on changes into endometrial cancer at some stage. So these are the key messages I want to give out to women. And that will prevent, like, if this message goes to the entire country, that would prevent at least, and the numbers would be talking in 6-7 years down the line would be very different.
Right. Thank you so much for that, Dr. Kumar. That's very, very good advice that's coming from you right now. With that, we come to the end of this webinar session on cancer in women. I hope to have many such sessions in the future to create awareness about cancer in women, specifically about breast cancer and cervical cancer. And thank you so much for patiently answering all the questions, which have been put to you from our viewers as well. So hope to see you again in the future sometime. Thank you so much.
Thank you. And thank you for you and Times of India for such a good approach to awareness for preventing cancers. Thank you.
Thank you, Dr. Kumar.